Hi all, welcome back. In the upcoming video, we are going to discuss how to take or obtain history from a patient present into the emergency department. I am Dr. S. Prakash Babu, Associate Professor of Emergency Medicine, KIMS and RC, Changalpattu. So how history taking differs when you see a patient in the ED and when you see a patient in the OPD. When you see a patient in the OPD, you are going to follow a schema. You are going to take complete history from the patient, then do a comprehensive physical examination right from head to toe, and then you are going to advise some investigations based on which you diagnose. Once you have a diagnosis, then you are going to prescribe some medicines and decide whether the patient needs to be admitted or can be sent home. Whereas in an emergency, you cannot spend so much of time in taking history and doing a physical examination before treating the patient. The patient might deteriorate and can die if you spend too long to take history and spend too long a time in physical examination and wait for diagnosis to start treatment. So medical emergencies require a shift recognition and a prompt action. Resuscitation takes precedence over elaborate history, and history should be focused on certain relevant positive and negative points. A precise diagnosis is not needed in most cases for stabilization of the patient. Once you think that the patient is stabilized, then you go for an elaborate and complete history taking, complete the physical examination, and then diagnosis can wait for some time until the patient is stable enough to be going through all these phases. So what you do, your priority is the ABCDE approach prior to an elaborate history. So you need to follow the internationally accepted ABCDE. You know what is ABCDE stand for. A for airway with cervical spine control, B for breathing and ventilation, C for circulation and hemorrhage control, D for disability, that is neurological disability, E for events and environmental control. This is the approach you need to follow for quick assessment of patients who are conscious. In unconscious patients, as per the ACLS guidelines, you are going to follow the CAB pattern. If an abnormality is found at any point or in any system, until you rectify that abnormality of that system, you will not be going to take further into the history. You need to reassess the patient after the intervention has been done to check whether the intervention was a fruitful intervention or not. So when you stabilize the patient using the ABCDE approach, you are going to take history, and this history is going to be a precise history with the relevant positive and negative points. You are going to follow a scheme called sample history for taking the history without missing any important points in the history. After the patient is sufficiently stabilized, take a focus history using the sample mnemonic. Sample stands for C, symptoms, and sometimes signs also. A for allergies, M for medications, P for past medical history, and L for last word intake or the last menstrual cycle in case of females. E, events leading up to the present illness or how the injury has happened and what are the events followed before presentation to the ED. So let us look at one by one. First, let us look at symptoms. You need to ask the patient what brought him to the hospital today. If you ask some leading questions, the patient is going to led by you and you will not get a exact picture what exactly the patient is undergoing. Allow the patient to explain on his own. You don't intervene as long as the patient is not interrupted. Support them to explain exactly by asking what else problems they have. Try to avoid any leading questions during the initial part of the history taking. So you follow OPQRST-AAA to evaluate each of the symptoms the patient is telling you. O for onset of the symptom. You can obtain this history by asking some specific questions. How did the symptoms start? what was the patient doing at that time, and whether the patient was symptom was sudden in onset or gradually progressed over a period of time, which gives how the symptom has started and how it has progressed. Provocation or progression, whether any movement, pressure, and external factor worsen the symptom, or whether there are any relieving factors for the symptoms, whether the symptom is stable or progressing over time. This is progression. You ask about the quality of the symptom, ask how much the patient is debilitated by the symptom, progression over time. Region, which part of the body the symptom correlates with. Radiation or referral, especially in case of pain. Severity of the symptom, how severe is the symptom. Timing, what happened to the symptoms over a period of time. Associated features is the most important. What are the accompanying symptoms along with the chief complaint? For example, patient's main complaint would have been fever, which has been associated with vomitings and diarrhea. Aggravating and aggravating factors, the factors which increase the symptoms, are the factors which reduce the symptoms, like a specific position, specific drugs, or any specific intervention that alleviate the or aggravate the symptoms need to be collected. So when you come to pain evaluation specifically, you can easily remember pain evaluation by using the mnemonic SOCRATES. S for site, where is the pain or the maximal site of the pain. O for onset, when did the pain start and was it sudden or gradual. Include also whether it is progressive or regressive. Character of the pain, what is the pain like, an ache, a stabbing. Radiation, does the pain radiate anywhere. Associations, any other signs or symptoms associated with the pain. Time course, does the pain follow a specific pattern of timing. Exacerbating or relieving factors, does anything change the severity of the pain. And finally, how bad is the pain. You can use the universal pain scales for evaluation of pain. Certain tips during taking history. A good opening question will encourage the patient to explain in their own words. Do not intervene unless you need more details about a particular incident. Help the patient to elaborate if they appear to be struck or unable to narrate the story. Don't let the patient elaborate on unnecessary information. Don't use any medical terminology during history taking. Document all the historical points, patient's own words, not in medical terminology, to save you from any litigation afterwards. Allergies. You need to ask the patient whether the patient had an allergic reaction earlier. Start with most significant allergic event, that will give you more information, because the patient will remember if has been hospitalized because of an allergic reaction, or if he underwent a significant amount of disturbance in his life due to that allergic event. Patient will remember that the most. It could be either a medical cause or environmental, like drugs or food or exposure to pollen or something. Ask them to describe the event and let them tell the medication if they don't know, if they have an anti-allergic medications or any specific medications they are allergic to, if their doctor has been explained to them. So medication history, ask the patients for medications they are on currently. Only medications used regularly could make sense unless you are suspecting an allergic reaction to the presenting illness with a single dose of some drug used for the current illness. Usually when you ask about what medications you are taking, there is a tendency for the patients to tell what exactly they have taken today or tomorrow outside of your hospital. When a family medicine doctor or a primary healthcare physician has prescribed some medicines, they will tell these are the medicines I am taking. So you need to be very careful. Review the old medical records if available. That will give enough information for you to document the medication history. Review the medications the patient is having. Some patients carry their medications in their small boxes or pouches to the hospital. They will show you. You can review those medications and you can get a fair idea about what medications the patient is having. Based on those medications, even if the patient is not telling you, you can tell what ailments the patient has had in the past. Especially inquire about any recent stoppage of medications, change of medicine, either prescription or over-the-counter medications. That will give you why the symptom has been exacerbated, especially when a patient presents with sudden uncontrolled diabetes mellitus or sudden uncontrolled hypertension. That there is every chance that the patient might have missed the drug. So you need to specifically ask whether the patient has any recent stoppage of medications or change of medications, which might be change of medication dose is very important, because whatever the patient is taking might not be enough to control his ailments. Next comes the past medical history. This is very important. It gives a fair idea, and half the diagnosis is given by asking the past medical history, especially in elderly patients. Review the past medical records if available. They will give much information to you to decipher. One can have fair idea of what the patient is having from the medication history also. Confirm those illnesses from the patient. Specifically ask about diabetes, hypertension, bronchial asthma, COPD, hypercholesteremia, including triglyceridemia and tuberculosis. Even if the patient is not telling you, ask about these diseases. Ask about duration of ailment, whether the patient is undergoing regular checkups, and how well the condition has been controlled. Ask specific personal habits like smoking and alcoholism. Smoking history and alcoholism history makes sense in patients, especially who are immunosuppressed or patients presenting with any diseases related to the vascular system like CVA or cerebrovascular accident or myocardial infarction. Smoking and alcoholism has to be asked specifically. When asking about smoking, you need to ask when did the patient start, how many cigarettes or BDs he used to smoke every day. So you can calculate the pack years. And then if the patient has stopped recently smoking, why did the patient stop? Is there any relation between the current medical condition and the stoppage of smoking? And ask specifically about alcoholism. When you are asking about alcoholism, every patient has a tendency to deny that they doesn't consume alcohol. When you ask, do you drink occasionally? They will tell yes. And then when you still probe, how frequently will you take? They might tell once a week or every day. Then you can ask about the quantity, how much they are taking. And finally, you can decide whether it is a moderate alcoholism or a harmful alcoholism. Last meal. When the patient is unstable and you prepare to intubate the patient, last meal becomes very important. Ask about the patient, when the patient had last meal, nature and quantity of the meal, patient's appetite, social and daily activity, life stressors, questionable food intake, and changes in diet regimen has to be asked specifically. They give you a fair idea about what was the patient's diet like in the first few days. Any recent changes in dietary pattern which could have led the patient for this present condition, especially in relation to diabetes. When was the food prepared? That makes sense when you are dealing with a patient who has presented to you with diarrhea. Where did he eat? Whether it is at home, outside, or parties. If anyone who ate along with the patient the same food had any similar complaints, which indicates an outbreak. Events preceding and following have to be asked. Ask about any recent activities. Where was the patient before the onset of symptoms? What was he doing? Evaluate it into any emotional component associated with the present complaints. Any recent stressors like family, economic problems, loss of a loved one, which can precipitate an MI, or the patient might mimic like MI symptoms. So this history becomes very important when you are taking history on a patient who has presented with MI-like symptoms. In patient asks, trauma patients ask complete details of the event, during the event and following that event. That will give you a fair idea how long the patient has been injured and how long it has been elapsed since the accident. Any medical symptoms like syncope, giddiness, loss of balance just before the event are usually overlooked. And when you see a trauma patient, you think whatever is the patient is undergoing is because of trauma. But before the trauma, patient would have had syncope, which has led to the accident. Patient would have giddiness and loss of balance, which have led to the accident. You need to evaluate for those symptoms also. That becomes very, very important. So some clinical pearls in history taking. A good history along with physical examination almost always clinches the diagnosis. Let the patient explain his problem in his own language. Until the patient stops or finds it difficult to continue the story, you should not intervene. Whenever you're documenting the history, you need to document in patient's own words. Remember, patient's own words, do not use any medical terms in documentation of history. This becomes a medical legal complication if you document in medical terms, and tomorrow if the case goes to court and patient can deny this is not what I told, and patient can explain his own words, then it becomes a medical legal litigation for you. So as far as possible, documents patient history in patient's own words. Laboratory diagnosis investigations support or complement the diagnosis, but diagnosis is not essential for stabilization and decision making for emergency patients, and history can always wait before stabilization. A good subjective history takers are masters of diagnosis and patient management. So use your skills for a good history taking, communicate with the patient, develop a good rapport with the patient, obtain whatever history you take, but especially in the emergency department, do not spend long time in history taking. Take relevant negative and positive points. Until now, we were talking about only the positive points in history taking. Negative points in history taking becomes important. As we go on system wise in the upcoming lectures, we will know how to deal with each symptom. Thank you. If you want my videos to be delivered directly to your inbox, please like and subscribe the videos on YouTube. Thank you all.